So a warm welcome to today's meeting of Wye Valley Trust Board. I'm standing in for Russell Hardy, who's having a well-earned break. And I want to begin the meeting just by saying a few words, really about what a tough summer we have had, both in our acute hospital and in our community services. The COVID pressures have certainly eased greatly, but it has not gone away. And everybody is working flat out to restore the services that we had in place and to begin to tackle the backlog of waits that we have for appointments and treatments. But we've had some real body blows on the way. I mean, we've had some real problems in bringing on stream the extra bed capacity that we desperately need. Problems beyond our control to do with building problems. And if that wasn't bad enough, many of our colleagues have had to mourn the untimely passing of two very dear colleagues who have passed away this year. That's Howard Oddy and Mel Bolton. So that's been a real blow. And at times it must have felt to our staff as though they're just surrounded by a sea of troubles and problems. Yet people are continue to work their socks off. I had a couple of personal appointments in the eye unit in the last few weeks, and I saw for myself how frantically busy it is and how hard people are working. So this is a timely moment at the start of this board meeting for me, on behalf of Russell and indeed the board, to express our appreciation again to all of our staff for everything that they're doing to serve the people of Herefordshire with their healthcare needs. And it's also a good moment, I think, to express our thanks to members of the public who continue to be so supportive and appreciative of those efforts. And as we enter the winter, and goodness knows what that is going to throw at us, we will need and we will value that support from the public more than we've ever done. So it's a kind of big thank you to everybody, both working in the hospital and in the community services, and the public who support us and bear with us at a time of great pressure. Thank you for that. So we have apologies from Russell, who I've explained is on holiday, and from Erica Herman. At this juncture, I'd like to welcome a new board member, that's Francis Martin, who is an associate non-executive director and will be playing a lead role in our arrangements with our new integrated care executive in Herefordshire as part of the national move towards integrated care systems. And Frances brings great experience and expertise, and I'm sure she will be a highly valued and valuable member of the board. So welcome, Frances. Are there any other apologies? No. Okay. Any declarations of interest? Or new declarations of interest, I should say. No. Okay. So then let's move on to minutes of our last meeting on the 6th of August. So first of all, are there any matters of accuracy or inaccuracy rather that people want to draw attention to? Okay, I'll take that as agreement with the minutes. We can sign those as a correct record. And then on to the follow-up, the actions update. And this looks straightforward. I've got my papers on another screen here, so that's why I'm looking sideways. So we've got a couple of completed items and some actions in progress. Any comments or questions about that? It all seems straightforward. Okay, so any other matters arising that people want to raise?
So Richard, can I just raise one other matter arising?
Yeah, sure.
So on page 8 of the minutes, the item 140821 relating to the Ockenden report. So we discussed last month the letter that we'd written to regional and national colleagues to raise concern about our allocation. Story was actually picked up by the Health Service Journal, and they're running it today, actually. As a consequence of either the letter or the story, I had a conversation with the chief nurse last night. Firstly, she clarified that our funding the recurrent impact of our funding is 120,000 rather than the 80,000 that we quoted. That wasn't actually clear in the letter at all, so we are seeking to confirm that, which would be helpful. Notwithstanding that, it's still significantly short of what would be fair shares. She also confirmed that they are willing to look at our position, and they will come back to us on the points that we've raised. That's likely to be potentially non-recurrent assistance rather than recurrent assistance, but it's helpful that they've agreed to review it. That's
okay, thanks, Glenn. Do hope you're not on the naughty step as a result of your comments at the last board.
Feels like I might.
Yeah. Well, we're right behind you. Okay. Any other matters arising? Okay. In which case, we'll hand back to you, Glenn, and your report. Yes.
Thank you very much, Chair. So I'm not going to go through the report in its entirety. There's a lot in there this time, mainly because I've provided some details on a lot of guidance linked to the legislation that's come through over the last few weeks, so I won't go through all of that. Just a couple of things to pull out from the rest of the report. Firstly, new wards. I give an update there. We still haven't got a firm handover. Jane and Alan and team are working hard with the contractors to secure that. We hope to be in very soon. It's probably the best thing to say at this point. The other item on the second item in the report is really good news story around the GMC go ahead for the medical school at the University of Worcester. Really pleased to see that. A lot of effort's gone into that, including people like Jane Clark from our team who put time into to make that a strong case. Obviously now needs to be secured funding to put places through the medical school, and the integrated care system has written to the national team in order to try and progress that. But this is really important for us to offer that opportunity to develop people within our patch, and that hopefully provides a pipeline of recruits into the future, as well as offering more training and teaching opportunities for our staff, which many of them really enjoy. The guidance on provider collaboratives is there. We feature as a case study. I mean, just to reiterate on that, there's 3 bullet points on the second page there that talk about the benefits of collaboratives. Refers to specialisation and consolidation. I wouldn't want anyone to feel concerned that provider collaboratives are going to change the service profile of what we offer in Herefordshire. We're already in a strong collaborative within the group, and that's helped us to be more resilient. And we continue to work with system partners, particularly Worcester Acute, to make sure that we can maintain our service profile. The guidance on ICS, I won't go through all of that because there's plenty of it and there's more to follow, I'm told. And also further guidance on NHS people function. And we had a great workshop presentation this morning from Jeffrey looking at our recruitment and retention strategy about how we're going to ensure that we're the employer of choice locally. There's then a section from the surgical division. Again, lots of examples of new services and innovation within existing services, which is to their great credit. So lots going on. And then finally, we list the employees and teams of the month, including our own Lucy Flanagan listed in there. So that's lovely to see. No more important though than any other member of staff listed there, Lucy. It's just, but it's good to see on that list. So okay, so I would be happy to take any further questions from the board.
Thanks, Glenn. Could I use Chairman's prerogative and just raise one thing with you under demand and system workforce pressures section of your report, and I think we're mindful of the pressures that our social care colleagues are experiencing at the moment. and the potential impact that has on flow in the hospital, enabling people to be discharged in a timely way so the bed can be freed up for someone else, but also helping people to stay at home and avoid the need to come into hospital at all. And we might want to kind of come back to this in the performance report, looking at Jane, about what we're doing that and how we're engaging with social care partners.
No, it is a really important point to flag. In between this morning's workshop and starting this meeting, I joined the National Elective Care Board for a conversation about this, and everyone is reporting a problem with discharge. And it's multifactorial, but there is a real workforce crisis that we're obviously seeing growing over the last few years, particularly around domiciliary care. And as I note in the report, concern about the impact of the double vaccination recruitment challenge for care homes. So I think that one of the things that we're keen to do is to ensure that all winter plans are as joined up as they can possibly be. The domiciliary care sector is obviously quite a complex sector with lots of very small employers, and we probably need to think about our role in addressing some of those recruitment challenges as a lead provider within our system. So I think that's one thing, and Geoffrey touched on that earlier in terms of how we might do that. But that is a real worry. Colleagues in social care working really hard on this, but the workforce challenges have certainly not gone away. They've got a lot worse over the last few weeks.
Yeah, thanks, Glenn. Perhaps we can come back to that under the performance report. Jane, did you want to follow on from that?
Yeah, it was just that absolutely is the local picture is we haven't seen really since the beginning of COVID. We've had hardly any delays into Herefordshire, and we've got a lot of delays into Herefordshire. The vast majority of that is around package of care at home. So we've got some people who are stuck in the Home First service, and then some who can't get into Home First because of package of care. And the social care locally they're certainly looking at bringing more of that provision in-house, and that's absolutely one of the things that we're going to do together. And we're just in the middle of setting our integrated care priorities for the rest of this year, and one of those is going to be around recruitment of staff into those non-registered caring roles, and try and do that together and create career pathways so that we support social care as well as our own healthcare assistant workforce. It's not going to be quick, but it's certainly part of the strategy.
Thank you, Jane. That's helpful. Chris.
Thank you. I think it's a really great idea to include some updates from the divisions, and we've heard about the pressures, and I hear that. But meanwhile, there is lots of good stuff, new stuff going on, and I would commend that to colleagues and the public. The Section 29 review meeting is obviously very positive news. Does that mean, Chair, and excuse my ignorance, Chair and Glenn and Jane, does that mean that the warning notice is removed, or does it remain currently on our record? Thank you.
Yeah, so the nature of the way that the CQC is still working is that they don't remove such things until they carry out an inspection. They are reviewing that protocol because obviously it's been difficult for them to operate in that fashion over the last year or so. But that's the situation we're in at the moment. But obviously lots of activity has gone on to get us to a much better place. So I think we would welcome a re-inspection at any point in order to actually demonstrate that and lots of other improvements across the organisation.
Thank you.
Thank you, Glenn. Thank you. Frank.
Yes, partly to endorse what Chris has just said, but I was thinking the other day I've attended more than 100 of these board meetings, and I've never seen such challenging times, but I've also never seen so many gold nuggets of brilliant activity and achievement. And somehow I just hope that we can get that message out there, because I still don't think that the public in general realise just how much complexity and how much energy is going into achieving some of these things, and the team deserve all the congratulations and whatever we can do to tell the public about it.
Yeah, well said, Frank. Yeah. So any other comments or questions about the Chief Executive's report? No, well, thank you for that, Glenn. So let's move on, and we now on to our integrated performance report. Jane, would you want to introduce this, please?
I will do. And there are just three things I was going to talk about. I was going to talk a bit about the new ward, a bit about COVID, and then a bit about the future as well. So in terms of the new ward block, the drying out process it has to be done thoroughly. We can't have a building that's then going to have any damp in it into the future. So our latest intelligence is it's going to be the end of September. It's handed over, and the nearer we get to that, then the more firmed up that will be. But it is feeling like more of a firm date. I mean, that's clearly impacted hugely on our plans over the summer to do more elective work and improve our emergency urgent care pathways as well. But it feels like there is some light at the end of the tunnel. A bit about COVID. So say that third wave is really well underway, and I think at almost all times through the last 18 months, Herefordshire has been below the national averages in terms of cases per 100,000, and we actually went above that over this last couple of weeks, which was a sort of a surprising place for us to be. So where we are today is we've got 15 inpatients. One of those is in ITU. Those case rates are dropping now, though, so they got to nearly 400 per 100,000. We're as of the last couple of days, we're just under 300 now. So hopefully that's going to continue. But obviously we all know that schools are going back, and so that may be another time when things start to go up. I mean, what is important, of course, is that of those inpatients, the ones that we've had in this third wave, around half of those are unvaccinated. So it really does reinforce that message around, vaccination is the best defence for all of us. And on the news this morning, there's new research, isn't there, around it's a protection against long COVID as well as from serious illness and death. So hopefully that trend will continue, that the rates continue to drop. And then I did want to talk a little bit. Glenn talked about all the guidance coming out around ICSs, and obviously that's gathering speed, and the legislation's on its way. So just say a little bit more about what we're doing locally, because we're continuing to run very fast with this agenda. So we have moved from the transition board that we had in place for 18 months, and we've put that now as part of our structure. So the One Herefordshire partnership is now well in place. And what we're doing at the moment there is we've just finished reviewing the priorities we set 18 months ago, and we're refreshing those. So there'll be a refreshed set of priorities, which I'll be able to come and tell the board about next month, which is really for the next 6 months, 9 months or so. And what that will then lead on to is a set of Herefordshire priorities and integrated care strategy for Herefordshire. That's part of the legislation. So we've started that work, and so we would anticipate that our Health and Wellbeing Board would sign that off before the end of the year. So by March time, we would have a integrated care strategy that would look at the next 2, 3, 4 years of activity about how we're going to take things forward. So all of that work is going on, and we've had some big successes with what we've achieved so far. And again, I'll bring that back next month. In that as well is the PCNs. So we've certainly been hearing from our teams who work with the PCNs in our locality, and particularly our general managers in the locality teams. And those relationships are really strengthening, and the PCNs have now put forward the priorities that they want to be working on over the rest of the year. Our team has been very much involved in those. We saw those One Hereford partnership on Tuesday and signed those off. And again, I'll bring those back next month. But some really excellent priorities, and very much on that prevention and inequalities basis that's so important for the work that we do in the future. The Clinical Practitioner Forum has been fundamental as we've gone through in terms of having a very strong clinical voice in everything that we're planning to do. So that's going through just some changes to its terms of reference, so it can get itself into the position so it can really take on the responsibility that the CCG will hand over to it. So it becomes the clinical advisory group for Herefordshire and for our part of the ICS. And then lastly, and really importantly, Healthwatch have got a workshop next week around trying to get the community partnership part of our sort of new Herefordshire integrated care structure in place. And we've all got ways of listening to the patient's voice, the citizen's voice, whether that's through the local authority, our own stakeholder panel, GP practices have that. But this is a way that, as a system, we'll be able to hear the patient's voice, because we've all heard it time and again, haven't we? It's the gaps between that often let patients down. It's not the individual services. So for us to be able to engage with and listen to the public in a very joined up way, I think again is going to be a key plank of how we make sure we listen to the public and we respond to the things they're telling us as we go forward. So really, lots and lots still to do, but there's a huge amount of activity that's still been going on with that, and as I say, quite a lot to bring back, I think, to next month's board.
Thank you, Jane. And I'd just like to kind of reiterate your point about vaccination and COVID, and following on from my earlier points about the role of the public, and this is addressed at the public, that to help us, to help you when you need healthcare at your time of need. One of the practical things that you can do is make sure that you are doubly vaccinated, and everybody that you know, unless there's a compelling or overwhelming reason why they can't be. That's the best way you can help your local NHS, including colleagues in primary care, be there for you when your time of need comes. So thank you, Jane. Any comments or questions about Jane's overall overview before we move on to the individual components? No, in that case, let's move on to the quality section of the report. Lucy.
Thank you, Richard. Just a few points from me this month, if I may. So Quality Committee, you've received a number of quarterly reports in the last couple of meetings. So I just wanted to highlight some things from the pressure ulcer report and patient experience. So whilst our pressure ulcer performance, we're not an outlier, we perform well, we report very few serious incidents related to pressure ulcers. What I'm keen to see is a reduction in the lower graded pressure ulcers that occur in our care or on our caseloads. So I am really excited that we have appointed a new non-medical clinical fellow into our education team to help take forward pressure ulcer education and prevention for doctors, nurses, allied health professionals and other clinical colleagues. Falls, I'm noting the report that Falls Awareness Week is scheduled for the 20th of September, and Joe, our Falls lead, has come up with a really innovative programme for Falls Prevention Week, and Christabel Hargreaves, as our non-exec chair of Quality Committee, and myself will be going out to judge the poster displays related to preventing falls during that week across our acute and community hospitals. I note in the report some of the activities that we're doing to take forward the feedback from our patients. So I note some of the things that we're doing there, and the particular focus on them on that is around communication with our patients and the information that we provide to them. We know that the nurse-led ward rounds on our surgical wards are going really well and are receiving really positive feedback from our patients. And then the new patient safety midwife has also introduced walkabouts on the maternity unit, and they're having a really positive impact too. There's the Quality Committee also received the Infection Prevention Quarterly Report at its meeting last week, and overall our performance for infection prevention is really strong, But as we know and I've previously reported to board, we are an outlier for our Clostridium difficile infection rates. So I just include a chart in there around our trajectory and our performance year to date. As board are aware, we changed our antibiotic prescribing at the beginning of July with an aim to reduce the incidence of infection, but it's too soon for us to know whether that will have the desired impact. Probably be 3 or 4 more months before we know if that's having the impact that we're hoping that it will. And then finally from me, just a little bit on staffing. Staffing during the last month has been exceptionally challenging, I think driven by a number of things. Our underlying vacancy factor, staff sickness, some staff being pinged and having to self-isolate. So tremendously difficult across all areas, but particularly difficult at our community hospitals. So one of our community hospitals in particular has a significant registered nurse vacancy factor, and we don't have any immediate solution to that, in that we haven't got registrants in the pipeline coming to join that workforce. We are managing it and mitigating any risks associated with that by redeploying nurses from the acute site into that community hospital to provide ongoing support. And we do have some medium-term plans to address that nursing shortage within Ross Community Hospital. On a positive note, however, board will recall that a couple of months ago I reported significant concerns around staffing gaps within the city district nursing team, and that they really had got to a critical level. What I'm pleased to note is that 2 really experienced district nursing sisters were moved from other parts of the county into the city team to provide some additional leadership and support. And that's enabled us to bring a number of nurses back from long-term sick and sickness and really stabilise that team. And we know staff have told us that they're actually enjoying coming back to work in that team now. So that's a good news story. And then thirdly, there's a little bit in there just around agency spend. And for colleagues that were at the workshop this morning, Jeffrey did the presentation on our workforce strategy and plans for the future. I do think our agency story is a good news story if you look at it over 2 to 3 years. And as you can see from the report, really our agency spend is being driven by 3 areas. So our community hospital, because of the vacancy factor there, our emergency department, partly because we're having to staff escalation areas because of the demand at the front door, and within our respiratory service because we're having to run 2 respiratory areas, one for COVID patients and one for non-COVID patients. So they're the 3 areas driving agency spend, but actually all other areas are performing particularly well. And that's all I've got to say, but happy to take any questions. You're on mute, Richard.
Sorry, I was just saying that there is so much going on, isn't there, across the quality agenda, as those of us on the quality committee know only too well. Any comments or questions to Lucy? No? Okay, that's good. So we'll move on then. Activity and operations, John.
Thank you, Chair. I'll take the report as read, and I'll leave all things planned care till the presentation later on, which covers it in a bit more detail, but it's obviously detail in the report as well. Happy to take questions if there are any. In terms of emergency demand, I think there's still a degree of volatility around demand, and much of the rise we're seeing is really being driven by self-presenting patients. Ambulance conveyance is volatile as well, but the underlying numbers, the average rolling numbers are not dissimilar to pre-COVID levels, although the spikes are quite sharp and difficult to manage. I think SDEC is worth picking out as a highlight, both in terms of the work is now all but complete. There's a few snagging issues to resolve, but the work is complete in our emergency department and our SDEC, and that's working well. And despite all the challenges for staff that Lucy just alluded to, across both nursing and medicine, we've seen over the last 6 weeks or so, that Sept still achieving 39% of all patients admitted being discharged on the same day, which is really, really good performance and definitely bridges the gap between sort of where we used to be, where we'd manage patients' admissions with escalation spaces, and where we are now, where we can't do that because of COVID restrictions. So they certainly do make it a lot easier for us to manage the demand that we face in the beds that we've got. And there are some exciting opportunities. And I know at last board workshop, the team invited people to join the huddle they have each day. And I know that a few of us have done that, and they are enlightening. They're frantic in pace with an awful lot of detail and an awful lot of patients they're dealing with, but they are enlightening. Great to see the level of joint working in that department, sort of in action, if you like. I just point out as well, bed occupancy. I was reading through my own report earlier on and thought I'd just point out I am doing some work regionally to try and make sure that our bed occupancy is more reflective. So it would look there as if we've got empty beds at midnight every night, which I assure you we don't have. It would suggest that we had enough to manage our demand, which I assure you we don't have. In fact, every day we probably come into about 15 patients or so that don't have beds, that need beds for the rest of the hospital full. What few beds we do have, and for those that get my daily briefing, are usually committed to COVID or elective care, and we usually use within the day anyway. So I am doing some work because I think there's some technical counting things that are being misrepresented there, and we are very, very tight for beds at the moment. It's really quite difficult. I'm looking forward to hopefully the start of October and some respite from that pressure. Other thing I thought I'd like to pull out really was TIA performance. I met with the team yesterday, actually, a few of us. And it's in a much better place than it has been, certainly for the 6.5 years I've been here, and consistently so now. And there's really some really good work going on in that regard, and I'm really quite pleased about that. And then finally, best practice tariff for neck which isn't very good. It's consistently not where it needs to be. But I was lucky enough to meet the new substantive orthogeriatrician the other day, and I say I was very impressed with both the enthusiasm and ideas about things that we need to change. And obviously, with opening the new wards and the dedicated orthogeriatric beds, I think we've got a sort of a much brighter horizon to look forward to for patients that suffer a neck fracture coming into our care. So I think that's really optimistic, really. I'm very excited by that. Looking forward to it. That's all I wanted to really highlight. Thanks, Chair.
Great, thank you, John. Very crisp and clear, as always. So any comments or questions to John? While we're waiting, I mean, John, I just wanted to raise something, but it might be better under your later presentation about winter and our winter plans, and to what extent we're going to stress test them before we get much further into the year.
Without wanting to seem facetious, I think we're stress testing them now, if I'm absolutely honest. There's not really. I mean, I think it's more about how do we drive down all the things in terms of length of stay, admission avoidance, working across integrated care. I think escalation plans are well and truly tested, and we'll just need to flex in and out of escalation as an opportunity arises. I think we're talking all the time about how we might increase resilience. Yeah. And also, so I'm not sure, we are going through the process. We're just about to start have our second urgent care summit across the health and social care economy, talking about what we can do working together differently to make it easier for each other to manage the collective demand that we face. But I think the days, well, certainly COVID has sort of flattened that spike out a little bit. It's hard to predict, but it could be a tough winter with RSV, flu and COVID in high numbers potentially. But I think we're as prepared as we can be for that.
Yeah, sure. The omens do not look good, do they, in terms of flu and other respiratory stuff, quite apart from COVID. But okay. Any other comments or questions? No. Okay. Thank you, John. And let's move on now to workforce. Jeffrey, we had a benefit of members of the public watching this. We had a very comprehensive presentation at our board workshop this morning about the quite profound challenges facing us, like all other NHS organisations, and more importantly, what we're doing about it. So, how's it looking, Jeffrey? From your point of view?
Thanks, Richard. Just some key highlights from our report. I mean, obviously, you mentioned the board workshop we had this morning. So, a key part of my work over the last few weeks has been developing a more comprehensive workforce and recruitment and retention strategy. So we had an overview of that this morning, and the final strategy should be ready by October time, which will then just show how we're going to be addressing the key challenges that we are faced with in terms of workforce and recruitment and retention. We continue to focus on health and well-being because that's quite crucial for us as an employer. And next week we will be promoting the national campaign, which is Know Your Numbers, and we're working with Blood Pressure UK to just try and raise the profile about encouraging people to know their numbers, because we know that high blood pressure is this, a silent killer, as people know. And certainly from our perspective, we're trying to just raise the awareness amongst all our staff and also playing our part across the local public as well. My report also captures the action plan which we've developed and putting in place in terms of some concerns raised in the staff survey on bullying and harassment. So some concerns came to our attention. So we've got some good plans in place, and we're putting things in place as captured within my paper, and we will be supporting some national projects as well in terms of raising the profile on zero tolerance on any bullying and harassment within the organization. And the report also just gives you a summary of the people poll, so the quarterly survey that we now conduct within Wye Valley. So if you look at in my report, just a summary page which just shows overall good results for Wye Valley compared to the NHS overall. So more work to be done, but we're certainly on the right path in terms of the actions we're putting in place for health and well-being, communications, leadership, and supporting staff throughout the pandemic and as we go forward. Those are the key highlights from our report, Chair. Happy to take any questions.
Thank you very much, Jeffrey. So any comments or questions to Jeffrey on the people issues? Christabel.
Thank you. It's very formal, Richard. Thank you. I would just commend the action plan. Thank you, Jeffrey, for you and your team putting that together. We've had quite a few different pieces of information that have brought this to our attention, and as Freedom to Speak Up non-exec director for Wye Valley, I would support all that you are doing in this area, and if there's anything more that I can do to help, I will support you. It's really crucial piece of work, so thank you.
Absolutely. Yeah. Any comments or questions, Jeffrey?
No, just to say that we're working closely with certainly our Freedom to Speak Up Guardian, our trade union colleagues. So the action plan has been developed in close partnership with those key individuals. So we will carry on putting things in place.
Good to hear that, Jeffrey, because I'm conscious that staff are under so much pressure that it is very easy to say or do the wrong thing without intending to, isn't it? Yeah. So, I think it's, but we have to kind of, draw a line that we do have a zero policy. So despite the stresses and provocations, it's not acceptable. So it's good to hear that you're on the case. Okay. Any other comments or questions to Jeffrey? In which case we'll look at finance. Katie, tell us about the money.
Thank you, Chair. So I'll take the report as read, and I just plan on drawing out headlines on 3 key areas. So where we are year to date, what that means looking forward, and then a short update on capital and cash. So this is month 4, July position. So in month we've delivered another small surplus, 96,000, which brings us to a year-to-date surplus of £357,000. As we've said in previous months, although it's a small surplus position in year, we had a planned deficit, so that gives the variance to our original plan in a positive variance of £3.9 million. And as we've described previously, we're delivering less activity than we planned to, and as a result we're experiencing less cost, and we've also spent less than we originally envisaged on COVID related costs. The position at month 4 includes £2 million of income through the elective recovery fund. That relates to earnings in the period to date, and as we know, the threshold has now changed and we're therefore unlikely to receive any further elective recovery fund income, certainly in H1. We're awaiting the final guidance around how that may operate in H2, which may provide some further opportunity or risk. Pay's remained relatively flat, but what I would just pull out is that we've seen a stepped increase in medical agency cost this month, covering specific gaps, and non-pay we're continuing to monitor some pressure point areas around excluded drugs particularly. We've delivered 487,000 of CPIP savings year to date, which is slightly below the target phasing, and as we know, that target gets steeper as the year goes on, so that remains a challenge for us. Looking forward, you'll recall we said last month that when we were looking at the forecast outturn for H1, we were expecting it to be no worse than the 3.6 million that we were planning. The team have done some further work revising that at month 4, and we've shared that with the system and the regulator, and we're now planning a deficit of £1.8 million for the first half of the year. So we're a much improved position to that we'd originally expected, but for the reasons that we've just articulated. In terms of H2, there remains significant uncertainty and we await the guidance, as Glenn referred to earlier, so nothing further to update on that one, other than that, of course, we're working with partners locally to make sure we're keeping refreshing those numbers, so we're ready to respond once that guidance becomes clear. CPIP, as I've said, remains challenging, particularly with that accelerating profile through H2. We did have a focus on it in the August Finance and Performance Exec meetings, and we'll review progress with the divisions when we meet them again next week. And finally, in terms of capital and cash, so on capital, we've spent £6.7 million year to date, slightly behind the original profile, but that's around timing of schemes, so nothing that's causing specific concern. What we are going to do, though, however, as we would usually do, is undertake a mid-year review, both internally and with the system, just to make sure that we're still targeting those that limited capital resource to those most important priorities collectively. And our cash balance remains healthy, which means we've been able to continue that focus on prompt payments and meet our standards this month. I'll pause there and happy to take any questions.
Thank you, Katie. That's very, very clear. So in summary, it's a case of steady as she goes, not much to see here, but the future is very, very uncertain, isn't it, in terms of the financial regime and what money we will actually get. Any comments or questions, Glenn?
Just to emphasise what Katie said, I mean, our position highlights one of the problems with the way the NHS is managing its finances at the moment, in that we're better off by not doing elective activity. That's a position we shouldn't expect to continue. So we don't know what H2 is going to look like or the following year, but there's a realisation, I think, that there needs to be a closer alignment between income and activity for elective services, maybe not for other services, but certainly for elective as we try and speed through recovery. So the work that we discussed in workshop this morning around productivity improvement is really important to help us to do that.
Thank you, Glenn. And Nicola.
Hi, I say, Katie, I think with all the uncertainties and looking at all that's on there, I think you've now become the financial equivalent of a brain surgeon, because I think trying to navigate those changes is absolutely incredible. So huge well done for doing that. My question was around the comment regarding our share to the shortfall in the ICS system budget. And just the question is, will we get a summary of the ICS level and our contribution so we could see that full picture, or what are the intentions with that contribution and our, I suppose, the transparency and how we get to see that information?
Okay, good question, Nicola. So we're absolutely happy to share that kind of picture overall from an ICS perspective, because this is about how as a system we deliver that break-even position for H1, which is what we'd committed to do. But when we committed to do it, we didn't quite have all of the answers about how we would get there. And we revised our forecast position at month 4. Colleagues across the system will have done the same. I'm more than happy to share what that picture looks like. I was on leave the last couple of weeks, so it hasn't made it into this report, but I'm happy to bring that next month.
Thank you.
Okay, thank you. Good. Any other comments or questions to Katie? No? Okay, thank you very much, Katie, and to colleagues for all of those performance reports. So we now move on to the section of the agenda where we discuss items for noting and information. And we begin, it's back to you, Katie, for an update on the digital programme.
Thank you, Chair. So again, I'll take the report as read as a reminder that we're continuing to evolve this report to make sure it's capturing digital schemes in its broadest sense. And in terms of where we are with our own internal programme, so the Global Digital Exemplar and associated programmes, we're currently assessing the status as amber. So the programme continues to progress, and there has been some great progress in many areas. So EPMA, for example, is fully delivered and now moving on to further benefits. However, there's still a lot to deliver in the remaining timescale, and we are seeing some increased concern around resource availability to deliver everything that's required of us in that time frame. Also, I think impacted by some of the workforce pressures that we've experienced as an organisation. So we're just reviewing the rollout plan over the next couple of weeks to ensure it remains realistic and achievable, and if not, to understand what mitigations we may put in place. The report also captures some of the wider schemes that are progressing both internally and across the system. Some of those are in sort of scoping phase, some are now moving into implementation, and perhaps if I just pull out the shared care record, which is the one that I think we had a board workshop presentation on previously, that's progressing, and we're expecting to be able to use some of that data from October time within Wye Valley, but we're also going to use that as a test case within the ICS around how we approach the benefits realisation from some of these digital programmes, so that we've got a shared framework, if you like, around how we do some of that, and that will link into the best use of resources programme from a system perspective, but also then can link into some of the work that Audit Committee have asked for around benefits realisation from digital. I'll pause there.
Okay, thank you very much, Katie. Again, very clear. Any comments or questions? Nicola, I assume that's a legacy hand, is it? It is, yeah, okay. Good, okay, so we note that report on the digital programme. And now we're on to the restoration of services and a presentation from John. John, over to you.
I'll see if I can succeed where others have failed, which means this isn't going to work as I try and put it up. Let me know if you can see that.
Yeah, we've got that, John.
2 seconds. It always looks different when you open it there, doesn't it? That should be now because I can get it.
Yeah, that's good.
Thank you. Sorry for the slight pause there. Okay, so it's a similar presentation to 3 previous months, but it's obviously updated. In terms of referrals, really, this is week 20, so just last week. This is up to date. So I think it's we're still seeing high volumes of 2-week wait and urgent referrals, and that's driving the numbers. But I'm just starting to suspect that difference might be starting to change as both routine referrals of gaps closed on previous year and urgent referrals has also closed the other way. It's less high than it was compared to previous years. So we may be starting to see a little bit of movement and return to more normal levels, but a bit early to say. But still busier than we expected and busier than it was the previous year in terms of overall volumes. Outpatient waiting list for new outpatients is fairly stable. It has been for some time. I was quite worried about that early in the year. Our projections still suggest that it's going to be probably another 2,000 or 3,000 greater by year end, but there's some reason to be hopeful that it may not be. It all depends on referrals in, etc. And the follow-up waiting list, it looks like last month I reported it's starting to climb. It looks like it might be a bit more volatile than the new waiting list, but that isn't actually increasing at the moment. So we may just at the moment have managed to just keep those in some sort of balance rather than seeing them grow, which is good, because I feared that they would grow continually through the year. So time will tell, obviously, but keeping a close eye on that. Inpatient waiting list. Really, the point to try to make here is just very much you can see the impact over the last 6 weeks. So with the loss of elective inpatient capacity, what impacts that had. We were starting to make very small inroads in the volume of the inpatient waiting list, but that's now been reversed and we're almost at identical positions to we started the year, which is really disappointing. Although the numbers over 18 weeks are falling, we are treating patients still, and we're treating those longest waiting patients, but their place on the wait list has been taken by people with shorter waits. So not really where we want to be. We really do need to sort of, as soon as we can, restore as much activity as we can and start to tackle this. I'll just draw your attention to the bottom right, which I now can't see because there's what remains of the Teams thing on there. Just in terms of, new activity, just really to give a sense there. I mean, the graphs are great, but that little table on the bottom right talks about new activity percentage in 1920. We're at 95% of new outpatients compared to where we were 2 years ago, and 106% against plan. It's 103% for follow-ups and 111% against plan. And I can't see the other one now, I'm afraid. I don't know how I would go about seeing that, but inpatients I think it's at 70% and day case at 90% against plan and previous years, which is say again not where it needs to be really, and we need to increase that as soon as possible and try and maintain that throughout the remainder of the year as best we can. Move it on. All right. Imaging, non-obstetric ultrasound waiting list remains a real concern for us, and it has increased since the last time we reported here, with now over 1,700 patients waiting over 6 weeks, so a waiting list of around about 3,000 in total, with a wait of approaching 4 months in total for some of the longest waiting patients, which is a real concern. We have had conversations with primary care in the last week to talk to them about how we can manage that between us, and they were very positive conversations. We continue to pull together plans to maximise capacity and reduce demand and increase capacity outside the trust, which we have been successful in securing 2 additional suppliers of an extra 60 scans a week for us, which should start in the next week or so. If you do look in some detail, we haven't actually seen any real increase in the waiting list over the last 3 or 4 weeks. So I think we are now matching our demand. We just need to now find capacity to start to reduce the backlog in total. So other than that, I think our imaging weights are reasonably stable and doing quite well with additional resource in place. Just talk about the additional clinical resource. The mobile theatre is on site and is operational, and it's now been, I don't think it had been agreed this time last month, but it's now going to be there till the end of March, which is really good news. So we've got that for the next 6 months or so. We continue to the local independent sector, and we are looking at insourcing, bringing in consultants and teams to support activity out of hours. The 4 rooms to support virtual clinics in the Lionel Green building are now live and being utilised. The 3rd CT scanner is now being completed, although there are staffing constraints. We've heard a lot about staffing constraints today, but they are impacting our ability to fully utilise that. But the team obviously are working on that, and that will improve over time. We had thought we'd secured some respiratory mutual aid from a trust outside of the region. That unfortunately has fallen through due to their own pressures. But we are working within the region to see what we can do to help some of our longest waiting patients. And I've talked about non-obstetric support, ultrasound support, which will be online in a few weeks' time. And we continue to provide a mutual aid to Worcester for cystoscopy, lithotripsy and orthodontics. And there's an MRI on site, which in the visitor site, you can't miss it. It's a huge thing just by the Lionel Green building, and that's there for the next 6 months. That's staffed and that's working 7 days a week. So in summary, I suspect it's only a hunch at the moment that referral patterns may be beginning to normalise, but they're still very different to pre-COVID currently. And our waiting list profile, I keep reminding the ICS of this, is very different at the moment to anything we will have experienced before in terms of how long the tail is, etc. And that will be quite unusual for quite some time to come as we work through this and restore activity. So we'll need to be cognizant of that as we construct our plans, because our waiting list will have a very different makeup than it has done previously. Our outpatient activity remains really good, but forward look plans suggest the waiting list size will increase by year end. Progress with the inpatient waiting list has been severely hampered by inpatient capacity, and we continue to try and find solutions to improve that. Non-obstetric ultrasound remains a concern, and products. I've just finished, I think, for the last 3 months at this same point, and we've heard a good presentation today about the work we're doing, but it's absolutely vital that we find ways to improve our productivity if we're to achieve the volumes required to deliver the timely care we want to do. So I think that's all I wanted to say, Chair. Thank you.
Thank you very much, John. And it does highlight, doesn't it, the scale of the challenge that we've got, really. And you know, it's not out of line with other trusts from what I can see. But thank you for everything that you're doing in your leadership on this, which I know is greatly valued. Glenn. Glenn?
Hi, sorry, I had a momentary loss of IT then, and I came back. So, John, I mean, thank you for the work that you're doing. As Richard said, the tail of the waiting list you referred to, obviously in your earlier performance report, we looked at an improving picture on 52-week waits. What's your view on whether that can continue that trajectory, or whether we've got some bumps that we need to be aware of? And then the other question is, one of the national concerns is around 104-week waits. I assume we're not in that territory.
52-week recovery slowed down, but is still going in the right direction. But it's tens a week improvement now rather than the hundreds we were seeing a few weeks ago. But so I think that will be a long tail and will take some time to recover. We are in 104-week territory, not in very high volumes, but in quite concerning volumes. There are pockets of patients that we don't have a solution to. One particularly is respiratory. We've asked for, say, I think I mentioned it, the mutual aid. There are some patients we've got limited clinical resource to see, and they've waited an awful long time. And I say we don't have a solution. Obviously, the respiratory team themselves are tied up with our COVID ward at the moment, and caring for 34-bedded inpatient area. The new wards will release some of that capacity to help with some of that, but we need to find other solutions as well. So there are individual capacity constraints that are going to be difficult. We had thought, and this was myself and finance colleagues, we had thought that we would get to no 104 days by September, but the problems with respiratory and inpatient capacity have confounded us a little bit, but we're still aiming to do it as soon as possible.
Okay, just as a follow-up to that, Richard, can we just make sure we are explicit about our 104-week position in future board reports, and then we can keep an eye on it. Thank you.
Yeah, that's good point. Thanks. Andrew.
Yeah, mine's a very specific question. Sorry, it's lithotripsy. I noticed in Glenn's report that lithotripsy is the only one in the West Midlands, I think it said, that's fully operational. And here it's mentioned as a mutual aid to Worcester. My sort of related question is, are they doing anything for us? Is there a sort of quid pro quo arrangement with them or something on some of the services, or is it a one-way?
I also read the lithotripsy thing. I don't know if that's a very specific, only one in the Midlands. I'm sure there's other lithotripsy units in the Midlands. It may be that particular device or approach that we're doing rather than a lithotripsy service.
Yeah,
so
other sites have a visiting service rather than a static service.
Yeah. All right. And on the Worcester issue, are we accessing them?
There have been offers of support from Worcester, particularly around access to theatres in Kidderminster, but we weren't able to take up, and we continue to meet weekly and talk about opportunities. So we are discussing that. At the moment, we were in a better position to create additional capacity to help them out with the very specific problems around their urology surveillance waiting list. So thankfully to the wonderful work that the team have done around our urology outpatient service, which has given that ability to flex that much more readily than others can. So we're in a particularly unique position with that service, really.
Thank you, John. And David, I spotted your hand this time.
Thanks, Richard. Yeah, John, I don't know if you're aware, we negotiated with the other inpatient consultant medical teams to support the respiratory team on Frome to allow them hopefully to start doing some outpatient work as well.
Yeah, I'd heard that. That's really good. I think that the particular 104 ways, actually thinking about some of those are around some specific treatments for allergy that needs a specific clinical resource. I think that's why we've asked the region for some support and mutual aid.
Okay, thank you, John. So any other comments or questions before we move on? Okay, so these update reports are really helpful, John. So please keep them coming. It's good to be cited on how we're doing. So somewhat unusually, I want to go back to the earlier item on digital program update, because I think a couple of people had got their hands up and for some reason I couldn't see it. So I wonder if we could just deal with those very quickly. I think the two hands were from you, Andrew, and from David. So David, do you want to go first?
Yeah, it was just a particular point about radiology order comms, Katie. Our GPs are in the unfortunate position of not being able to view results that they've ordered or perhaps we've ordered, which is starting to cause rework and inefficiencies in the system. So it's just to, if you weren't aware, make you aware of it, and I would vouch for that being kicked up the priority list. It would be really good to get.
Could you have a look at that, Katie, offline?
Yeah, absolutely. So we've done the internal order comms rollout, haven't we? And then the GP aspect was going to follow. But you're right, David. I think it's about that prioritisation and just reviewing, isn't it? So it's on the work plan, but more than happy to look with the team at how we expedite that element.
Cool, great. And Andrew?
Yeah, I'm okay, Richard.
You're okay, okay.
Yeah.
John, did I just see who your hand up?
Sorry, I'll take it offline, Chair. Sorry, it's probably too much detail for now.
Fair enough. I'm now kind of hypersensitive about not missing anybody's hands. I've got to frantically scanning the screen. Okay, so that's that then. So we now go on to looking at some of the summary reports from committees, beginning with the Quality Committee on the 29th of July. Christabel, anything you want to add?
Thank you, Chair. No, I'll take it as read, and lots of the comments I've made have been picked up elsewhere in Lucy's quality report, etc. I'll just bring to the board's attention to two things that haven't been mentioned today. Is the work of our research and development team. They go along quite quietly in the background, but they are the 5th highest recruiter to trials in the West Midlands. And for a small trust, again, we're punching above our weight. And I think the emphasis now is to try and see if we can get some more commercial trials going, because obviously we've got a fantastic team here and we want to utilise that. So, and the second thing was just to, again, draw the board's attention to the fact that workload across the safeguarding agenda is on the increase for all sorts of reasons, which we quite clearly would understand. But I would just say we're still very assured of the work that those teams do. And again, it's teams sort of in the background, but they do a marvellous job in keeping people as safe as they possibly can. So thank you.
Thanks, Chris. I strongly endorse your comments on the research and development work. We often comment positively about that at Quality Committee, don't we? What how important that is to the profile of the trust. So thank you for raising that. Any comments or questions to Chris? We're happy to note that update. Okay, so the second set of minutes is Quality Committee on the 24th of June. Again, Christabel, anything you want to add?
No, Chair, because we summarised those last month.
Okay, fine, thank you. Do we have any items of other business? Lucy?
Just very briefly, I think John alluded to it in his report around perhaps a difficult winter with RSV, flu and COVID. But just to note, we launched our flu campaign on the 5th of October here at Wye Valley for health for our staff. And we know that GP practices are already calling forward their patients for flu vaccination, which is really, really important coming into this winter. And we await the guidance from JBCI that are due to meet this week around the booster programme for COVID boosters.
Okay, thanks, Lucy. That's very helpful. Any other matters arising? I can see no hands up. If there are, just come off mute. No, okay, that's fine then. We have no questions from members of the public as far as I'm aware. And the date of our next meeting is on the 7th of October. So that concludes our agenda. Thank you very much, everybody, and any members of the public watching this. I hope you found it valuable, and thank you for taking the trouble to take part in our proceedings. Thank you very much, and we'll see some of you shortly. So if you could stop recording